Hello, everyone. My name is Min-Seok Soo from Seoul National University Hospital. And today I would like to host a TEIN Summer Workshop 2021. In this workshop, we would focus on the neuroimaging agents, especially for radiopharmaceuticals for Alzheimer's disease. So this will be, I think, might be helpful for whom have interest in the nuclear medicine neuroimaging and other physicians who are interested in the neuroimaging, and also like chemists who have interest in developing such a radiopharmaceuticals for the brain imaging agents. So actually this workshop is a start of the following lecture series, which will be opened up at 2021 second semester from September. So I would, at the last part, I would like to introduce some tentative schedule for the upcoming semester, and it will be mostly dedicated for the neuroimaging or brain diagnostics. Okay, so I would like to introduce some current conceptual change in the Alzheimer's disease. So why our neuroimaging agents, especially the brain Alzheimer's disease imaging agents, are getting a hype of interest. Okay, so Alzheimer's disease is a neurodegenerative disease that usually starts slowly and progressively worsens. And it is known to be the cause of 60 to 70% of dementia, which is the most common case. And most early symptoms is difficulty in recent memories. And as the disease advances, there are problems with like language disorientations or motivation or self-neglect. So as of 2015, there was approximately like 30 million people worldwide with Alzheimer's disease. It's about 50 million of all forms of dementia. And as you can see, prevalence in the Asian regions is high. And it is reported that the number of people with dementia in this region is estimated to be 23 million, which is like almost half of the entire world. And it is estimated to be increased to almost 70 million by 2050. So there is a increasing number of patients, and also because of it, there is an increasing care cost for this Alzheimer's disease. Currently, what I would like to introduce mostly for this lecture is that currently there are paradigm shifts in the disease classification systems for Alzheimer's disease. So beginning, we would like to see what was in the past and what is now in the current. So in the past, the National Institute of Neurological and Communicative Disorder and Stroke and the Alzheimer's Disease and Related Disorder Association, which is abbreviation of this NINCDS ADRRDA, proposed a criteria in 1984. In this criteria, the Alzheimer's disease was defined as a clinical and pathologic entity, which means that if a person had a gradual onset of cognitive disorder, like usually involving the memory, and if it leads to the functional impairment in the daily activity, this patient would be labeled as having dementia. And once other potential contributing factors have been ruled out, and this patient have a degenerative character, then this a patient is labeled as possible or probable AD. The disorder could only be labeled as a definite Alzheimer's disease when the person went on to have an autopsy and at post-mortem examination, if there is a neurotic plaques or neurofibrillary tangles. Sorry. And this criteria, this conceptualization stood for over 30 years and became so well accepted that the clinical diagnosis of this possible or probable AD was typically shortened to simply like AD. So now, like, it is not like possible, probable, but people conceptually know it as it is the Alzheimer's disease. However, there is some problems when from the numerous studies show that they're in like elderly, cognitively unimpaired persons could have numerous plaques and or neurofibrillary tangles at the autopsies. And also conversely, people with the clinical pictures of the probable or possible AD did not, in some cases, did not have the defining features of AD on post-mortem examinations. And furthermore, some like awkward problems for some recent randomized clinical trials for which have targeted the amyloid targeting agent have shown that 10 or to 30% of patients in that clinical trial had no amyloid plaque on PET scannings. So there is a problem of this clinical only diagnosis. And at the same period, the biomarkers for AD was evolving. So these biomarkers reflecting underlying amyloid and tau have been available for 35 years actually, which is particularly from the CSF. However, these CSF agents have some limitations because they are, there is some wide variety over the laboratory to laboratory, and there is a actual resistance to the lumbar puncture. So in 2004, Dr. Klunk, working in Pittsburgh with colleagues from Uppsala, Sweden, demonstrated the utility of C11 PET radioligand, which is the Pittsburgh compound B. And this can be used to identify the amyloid plaque in living person and change this field dramatically. So this clinical profile coupled with this amyloid positivity on PET can now strongly suggest the diagnosis of the Alzheimer's disease. So starting from the PIB, there were several fluorine, also fluorine-based compounds, which are florbetaben, fluorometamor, or Florbetaben, have been developed and received approval from the FDA, US FDA. And another drug, this you can see prolapronor is, which is the name is Alzavue, is an agent which has acquired approval in Korea. So there are like 4 right now fluorine-based amyloid imaging agents which have Korean or US FDA or EMA approvals. So as you will know, this amyloid imaging as the disease progresses has a features of amyloid, can show amyloid accumulation. And at the beginnings, there are accumulation dominantly in the frontal cortex and precuneus areas. And as the disease progresses, there is a accumulation shown in the sensory motor cortex and medial temporal cortexes. And at the later pace, there is a uptake in the pons or cerebellum. So I would like to show you the imagings. So in the right side, you can see that the cortex, there is a again, as you can see, the uptake in the cortex and the white matter is not undistinguishable. So there is a diffuse uptake along the cerebral cortex, which meaning there is a positive amyloid plaque accumulation in the brain. However, in the left side, as you can see, right side, you can see that there is a distinguishable no uptake in the cortex compared to the white matter of the brain. So we can indicate this as a negative scan. So for the Florbetaben scan, we have adopted the brain amyloid plaque road scoring system, which is the Bakker scoring system. And it uses a predefined 3 grading scoring system. And it is made by the physician according to the visual assessment. And you can refer to how we score following, you can see by this table. And so since the development of the PIV in 2004, there has been various amyloid imaging agents are now currently being used in the clinical practice. And from diverse and many clinical studies, it had made a consolidating position as biomarkers for the Alzheimer's disease. So such an advance of these biomarkers actually led to a revision of the Alzheimer's disease criteria in 2011. So the important part is that it actually put this biomarker as a diagnostic. It had put this used this biomarker as a criteria. So firstly, the clinician, when the patient comes, the clinical continuum of the Alzheimer's disease was divided into 3 phases like preclinical, MCI status, and dementia. And after dividing into these 3 phases of the Alzheimer's disease, the patient underwent biomarker studies. And with this combination of biomarkers, it can actually give a confidence that the underlying clinical syndrome was likely due to the the Alzheimer's disease pathology. So for example, what it means is, for example, like for MCI, if you want to diagnose patient as a MCI due to Alzheimer's disease, the first thing is, firstly, the patient should have a clinical syndrome of the mild cognitive impairment itself. And next, it's various combinations of biomarkers for amyloid and neurodegeneration, the possibility of Alzheimer's disease being the underlying etiology increases. So when there is both measures of amyloid and neurodegeneration, then the diagnosis of MCI due to AD have a high likelihood. So the revision, the most important point of this revised criteria was incorporation of the biomarkers. And further, since this 2011 criteria, there has been studies, and the most important part of amyloid imaging was that there has been many imaging to autopsy comparison studies. And now this amyloid imaging has gained as a in vivo surrogate marker for non-invasive pathologic marker for A-beta deposition. And it is now also widely accepted that CSF A-beta also is a valid indicator of the abnormal pathologic state. So now this amyloid imaging has gained a importance that it can actually be used as a non-invasive pathologic biomarker. But again, you should think is that syndrome is not an etiology, but rather a clinical consequence of one or more disease. So a biological definition of Alzheimer's disease is a logical step toward like better understanding of the mechanism underlying its clinical expression. Like for example, when you diagnose a cancer, it is actually based on the pathologic results, not by the clinical symptom of the patient. So like that kind of similar conceptualization was actually adopted in this 2018, our most recent recommendation from the NIAA research framework. And also what have actually accelerated this new conceptualization of the new framework was due to the development of our new PET ligand, which actually targets the pathologic tau. So this neurofibrillary tangles are aggregates of the hyperphosphorylated tau protein, which is known as a primary biomarker for Alzheimer's disease. And this tau PET is now a new modality, and the ligands that have been evaluated to date are considered the first generation compound. But however, these first generation compounds have some limitations. The most commonly are known to be the off-target binding. However, the autoradiographic studies have shown that this AV1451, which is called to be fluorotalsipir, does show that it has less bind to amyloid plaques, and like it has a less off-target binding. And as a result, this fluorotalsipir taubid has been the first FDA-approved tau agent to be in the clinic. So, as you will know, this elevated tau binding, PET binding, is mainly usually shown in both medial and temporal lobe structures and at the neocortex. And this binding in these regions are strongly associated with positive amyloid PET scans and with the clinical impairment. And also this uptake of the fluorotalsipir correlate with the broad neurofibrillary tangle staging, as you can see from the image. The more importantly is that this study have shown that this prospective longitudinal atrophy and Alzheimer's disease correlates with the intensity and intensity of the tau PET. But as you can see, but not correlate with the PI amyloid. So what it means is that tau pathology is a major driver of the local neurodegeneration. And actually this highlights the relevance of the tau PET as a precision medicine tool for like therapeutic future clinical trials actually targeting this tau agent. And moreover, what have known is that the underlying clinical phenotype of the Alzheimer's disease was associated with the regional distribution of this tau PET agents. So as you can see, like in the upper row is the typical AD group. And these had a uptake was observed, as you can see in the image, in bilaterally in the posterior cingulate and precuneus and lateral temporal parietal lobes, and in the occipital cortex, and also in the medial temporal cortex, and which is actually consistent with the Brock stage 5. But however, as you can see in the patient with other atypical clinical Alzheimer's disease syndrome, such as PCA or or a lopogenic variant primary like progressive aphasia or cortical-basal syndrome patient, this tau imaging have shown a different patterns and which is actually associated with the clinical syndrome. So for instance, for the PCA, the posterior cortical atrophy patient, tau uptake was usually prominent in the occipital, parietal, and like this visual association areas. So, and also what this study showed was that this cortical atrophy and this regional special patterns were correlated according to the cortical thickness. However, there was no correlation with the PIB, the amyloid imaging. What is more important about this special difference in the pattern was that regional distribution of the tau imaging can actually be used for the differential diagnosis of these different diverse taupathies. So now, new tau PET ligands are in the early stage of development and evaluation. And there is some optimism that these second generation drugs can actually overcome limitations of the first generation compounds. So it might be interesting to see what will be the next agent to be used in the clinic. So using these newly developed and also consolidate this amyloid imaging agent and newly developed tau imaging agents. And now it is possible to detect the presence of these neuropathologic features of Alzheimer's disease in a living person using the imaging. So this new Alzheimer's disease framework posits that the term Alzheimer's disease should be restricted to the person who have demonstrated the presence of these plaque and neurofibrous tangles. So what is important is that description of Alzheimer's disease are independent of the clinical status of the person. So meaning that this Alzheimer's disease description is no longer a clinical pathological diagnosis, but it's actually diagnosed by the biomarker. So there is a paradigm shift from symptom-based diagnosis to the biomarker-based diagnosis. So what I think is that neuroimaging in the nuclear medicine is gaining interest and hype. And also, moreover, there is a, and this change in the concept of diagnosing is anticipated that this framework can actually improve the design of the randomized controlled trials of drug development, which are targeting the Alzheimer's disease biomarker. And this will enhance the ability to enroll the appropriate participant, and it is actually following the biologically relevant biomarkers during the course of the treatment. So you can see some examples how this aducanumab, which is the first FDA-approved amyloid targeting therapeutic agent, and how they have gained this FDA approval. So it was from these two studies, and what they have shown was that they're using this aducanumab, which is the amyloid targeting agent, can actually reduce the degree of the amyloid burden using, and with how they have confirmed it was by using the PET imaging, that the SUVR in the amyloid was decreased after the treatment. And from the eMERGE study, they also have shown that for the primary endpoint, there was a improvement in the symptom. However, there is some controversial about this aducanumab because of the result of the second, this ENGAGE result, because there was no significant difference in the symptom improvement after the treatment. But still, this aducanumab had been the firstly approved drug in 2021 June by the FDA. And as you can see in the indication and usage, this aducanumab is indicated for the patient with mild cognitive impairment or which has a mild dementia stage. But there are some concerns or debates still, because in the dosage and administration, as you can see, there is no indication or no usage about the PET imaging. But there is a saying that it needs a MRI prior to the initiating of the treatment. So there is the latest controversy about the amyloid PET requirement. And I also agree that there is a need of amyloid PET before and after the treatment of this new drug, because this new aducanumab also gained the approval by the data that it can actually decrease the burden of the amyloid plaque using the PET imaging. And also, but also without such a requirement in the FDA label, because this amyloid PET now is a important tool for the diagnosis of the Alzheimer's disease, the usage should be necessary. Another concern is that there is a hype, and there are many more studies not using the CSF, but using the blood to detect such a markers like tau or amyloid markers. And these studies have shown that these blood-based markers have a very high sensitivity or specificities. However, I believe that these blood or CSF-based markers cannot have a different role compared to the PET imaging. Like amyloid PET, it is already, this amyloid PET has been established as a role for non-invasive pathology. So it can be widely used for new drug development. And more importantly, because as you have seen from the tau imaging agents, these tau deposition has a different spatial temporal patterns according to the different amyloid Alzheimer's disease subtypes, or also different among different tau species. So in summaries, there is a change in the Alzheimer's and dementia diagnosis system, which is from the symptomatic diagnosis to the biomarker-based diagnosis. And amyloid PET has gained its consolidated role as a non-invasive pathologic biomarker. And this newly developed tau agents have shown a high correlation between the tau accumulation and clinical symptoms. And moreover, this tau deposition has a special distribution pattern, and it is associated with different Alzheimer's disease subtypes and also different tau species. Okay, I think this was the last for my lecture, and following Professor Yoon-Sang Lee will introduce us about the radiopharmaceuticals used for the Alzheimer's disease. Okay, thank you very much. And I think we can move on to Professor Lee's lecture.
Can you hear me?
Yes.
Okay, nice to see you again. I'm Yun-Sang Lee and the chemistry team of our department. And today, we focused on the development of radiopharmaceutical for Alzheimer's disease almost 10 years ago. And also we published two types of radiopharmaceutical for Alzheimer's disease, that is the benzylidinanilin and also benzodiazepine derivatives. But unfortunately, we cannot adopt these compounds to the clinical trials because of that performance efficacy is not so good. And later on, in case of benzylidinanilin, we try to use for a tau imaging agent, but still we are going on for our in vitro study now. So we have several trials for development of radiopharmaceutical for Alzheimer's disease, but still we are struggling for development stage. So today we will review several radiopharmaceutical for amyloid beta plaque imaging and also tau imaging agent. And also you can see the history of the those compounds development. And in my presentation, Professor Yu-Kyung Kim gave me the several data for of her own cases. So as you know that in case of the dementia, you can see them almost more than 50 or sometimes 70% of is Alzheimer's disease. So as you saw the Professor Saw's slide, that there is a TEIN guideline or framework is undergoing from the year of 2011, and new version of the TEIN for Alzheimer's disease is published in the year of 2018. So you can see the aggregated amyloid plaque and also tau aggregate and also neurodegeneration is using for imaging biomarker. So already Professor Saw said that now that Alzheimer's disease is symptom-based diagnosis to the biomarker-based diagnosis. So after this framework, I think PET imaging is more interest in this field. So still MRI is the basic tool for Alzheimer's disease, and also FTG is a classical PET tool for neurodegeneration, and newly developed amyloid beta plaque imaging and tau imaging agent can be a new biomarker for Alzheimer's disease. In that TEIN criteria, I think amyloid plaque or amyloid beta deposition is first change in the brain, and then we can see the amyloid PET right after the accumulation of the amyloid beta plaque. And after that, CSF tau increase and follow up we can see the tau aggregation in the PET images. And also after this amyloid and tau aggregation is happened, and then finally we can see the brain structure changes from the MRI or FDG PET. And after that, we don't know that that symptom is coming from earlier or not, but almost all things happened, and then we can recognize that the cognitive impairment. Right after these images opened in a international conference on Alzheimer's disease and related disorder from the Pittsburgh, the Clunk group. And then this is the normal subject, and this images from the AD patient. So right after this images opened in the conference, and then next week that Science published that this long-awaited technique spot Alzheimer's toxin. So they said that the people are going to point this particular presentation and say, this is when we started making progress. So, so many researchers in the Alzheimer's disease field, they want to see the in vivo and non-invasive imaging tool for that Alzheimer's disease research for Alzheimer's disease. And Clunk and Mathis, they have struggled for more than 10 years to evaluate this compound for clinical trials or clinical first in human study. So they did a whole toxicity study and also BBB penetration. So as you know that we think that there are several pathologic changes in the Alzheimer's disease, and then also we think that this beta amyloid plaque hypothesis and tau hyperphosphorylated tau protein can make an aggregate form, and then we call that tau also can affect the Alzheimer's disease. So after the cutting of the gamma secretase and beta secretase, and then they can form the A beta monomer, and then after that they can easily form the oligomer, and then that can form the flux. In case of A beta oligomer can penetrate the BBB because of that is the highly hydrophilicity. So because of that hydrophilicity, so but some reason we cannot that oligomer cannot pass through the BBB, then they accumulate in the brain, and then they can form A beta fibers in the outside of the cell. But in case of neurofibril tangle, came from the highly hyperphosphorylated tau protein that is accumulated in the inside of the cell. So these two pathology has some differences because of A beta plaque is outside of the cell, and neurofibril tangle is inside of the cell. So the targeting molecule is that structure of targeting molecule for these two pathology is different. So first of all, we can discuss about the amyloid beta plaque imaging agent. As I mentioned, that the formation and accumulation of the aggregate form of beta amyloid in the brain, and especially in the outside the cell. So in vivo assessment of amyloid beta plaque in the brain will be useful in early diagnosis and monitoring the progression of the disease. That amyloid plaque imaging agent came from these kinds of staining agent. More than 50 years they used for amyloid plaque staining. As you can see, a Congo red can visualize that amyloid plaque beta sheet accumulation in the brain tissue, and thioplavin T also has a fluorescence activity, and then they have this compound has a affinity to the amyloid beta sheet. So from these two Beijing molecule, they can use the amyloid plaque staining agent. So more than 2,700 brains can make these kinds of drug staging study. So as Professor So mentioned that start from the frontal cortex to the pons or cerebellum or white matter. So we hope that that amyloid plaque imaging agent, PET agent, can visualize these kinds of differences in the living brain. So as I mentioned, that the Mattis opened this PIB in the year of 2002, but in almost the same period, there are several candidates for amyloid plaque imaging PET tracer. Here you can see the FDDMP from the UCSF, University of California, San Francisco, and also Mattis opened this almost same compound with the PIB that is BTA1 is labeled with the C11, and IMPY is invented by the Hank Kung in the Pennsylvania University. And also Hank Kung made SP13 is also opened in a year of 2003. So only of the 2000, there are several candidates for the clinically used for amyloid beta plaque imaging. So you can see here, start from the PIB, that NAV 4694 is invented by the AstraZeneca, and that compound moved to the Namibia or Namibia. And flutemetamol is almost same structure of the C11 PIB. Because of the C11 half-life is 20 minutes. So it this kind of C11 compound can be used in the hospital in-house use. But F18 version of the PIB can transfer to the other hospital or other region. So that's why everyone wants to make a F18 version of PIB. So flutemetamol invented by the GE healthcare, that structure is almost same with the PIB, but that F18 yield is very low. But nowadays they could solve this production problem. And another compound is Alzavue, is made by the Korean domestic company FutureChem. They developed the almost same structure with the PIB, but they possess that hydrophilic portion in the F18 label. So we expect that this compound is somewhat higher excretion rate from the white matter, but result is not good. So you can see from the PIB skeleton, then there are 3 compounds, and then these 2 compounds are approved by the US FDA or Korean FDA. And based from the start from the Congo red, as I mentioned, that the SB13 is a C11 version of the this 2 benzoyl and then one ethene bond, and then they can form a flat structure of the whole chemical structure. And start from the sp13, they Hanka Kung invent the Florbetaben AV1 is simply elongation of the hydroxyl group into the, and then finally F18 is attached in the of the side chain. And AV45, that is the some differences between the benzene ring and then pyridine ring. So in these simple changes, they improve that the hydrophilicity. So they said that this AV45 is a better washout rate than the AV1. So these 2 compounds, Neuraceq is earlier Bial possessed this compound, and AV45 is possessed by the Avid, and then they sell this company to the Eli Lilly. So these 2 compounds were approved by the US FDA and Korean FDA also. So we can use these 4 Florbetaben and Alzavue and Florbetaben and Florbetaper we can use in Korean in Korea. So there are several differences between each PET tracers. In case of C11 PIB, after the injection, we have to get the image after the 50 to 70 minutes. And Amyloid, that AV45, after the 30 or 50 minutes after injection, and Neuraceq, that the Florbetaben, and you should wait for more than almost 2 hours. And flutemetamol is the same, almost same with the Florbetaben. And FC Alzavue, that Korean domestic product, is up to 60 minutes. And dosimetry is almost similar, and also that clinical imaging has slightly different in each compound. So here you can see the normal distribution of C11 PIB. So 40 minutes after IV injection, there are almost no uptake in the other region than the white matter region. So that PIB images, you can see the that blue region in the rainbow scale. But AD patient image of the PIB, that PIB retention in the AD patient brain, you can see the high uptake in the several regions in the PET images. And after the normal control and the AD patient comparison start from the MRI and PIB and FDG images, and there are no changes in the MRI, but you can see the high PIB or PIB uptake and decrease the FDG uptake in some region. So we think that not the morphological changes is happened in the AD patient. Still, we got the high accumulation. Even the patient has no symptoms, we can see the high uptake in the PIB in the PET images. And in case of Neuraceq, there is a negative scan, so that is almost same with the PIB, but still white matter region has a somewhat higher uptake than the PIB. And this is the positive scan of the patient, so high uptake in the whole brain regions. And then flutemetamol, Bijamil can show the slightly great higher uptake of the white matter and some brain specific region. And in case of patient, you can see the high uptake in the frontal lobe or other regions. And this is an Alzavue negative scan. Even in a negative scan, that white matter uptake is somewhat higher than any other PET agent. And also positive scan is show that the specific region for temporal lobe or other lobes. And then this uptake pattern is somewhat different. Negative scan and positive scan. That means negative scan shows a higher white matter, but positive scan show the outside of the brain uptake is higher. But they said that white matter uptake is related with the hydrophobicity of the that each radiopharmaceutical, highly related with hydrophobicity, but and also specific white matter kinetics that is related with the hydrophobicity. So hydrophobic compound cannot wash out fastly. So that's why white matter uptake is still high. And also, I think that that scan time can affect these kinds of matter because of the Neuraceq. Normally, we wait for more than 100 minutes after the injection. In case of Alzavue, we have to wait for 60 minutes after injection. So I think Professor Yu-Kyung Kim told me that every 4 compounds, she already seen the whole images of the AD patient. She said that there are no differences between 4 different traces. So any kinds of compound you can use, you can diagnose the AD or mild MCI like that. Here is the direct comparison of the F18 Florbetaben and CLM PIB, and with the same patient. And also you can see almost the same uptake of the PIB, and these are the Florbetaben. And then that SCVR is, and they compare the SCVR, and that R square is a 0.85, and result of the SNUH. And these Florbetaben and C11 comparison in a low-E group, they said that the del R square number is a 0.96. So that means almost same result of the same patient. And Florbetaben comparison, they said that the Florbetaben SCVR is significantly greater than the PIB of the SCVR of the PIB. And then, and also they did the 3 different amyloid ligand to the C11 PIB, and they said that the almost same R square value of the SCVR. So, as I mentioned that, and also I already mentioned that all 4 different F18 version of the amyloid ligand can show the almost same result with the C11 PIB. So if you can get those any kinds of PET tracer in your country, then you can use for amyloid plaque imaging. Next one is the tau aggregates imaging agent, tau imaging agent. There's also tau tangles of the Braak stage. You can see the high accumulation start from this area to the other brain. And this tau imaging agent came from the start from the inhibitor of the tau aggregation. So tau for Alzheimer's disease therapeutics. Max Planck Institute, they published several different kinds of inhibitor of the tau aggregation. Here you can see the PTH group, phenylthiojolyl hydroxide group, and also rhodamin group, and then anthraquinone groups, and phenylamine groups, and diacarbocyanine group. So every old compound possesses that conjugated, fully conjugated benzene ring, and also that benzene ring possesses the somewhat distorted angle of that. Still, they possess the plane structure, but this compound is a somewhat different structure of the amyloid plaque imaging. So still we have obstacles for tau imaging agent. Tau PET is already used in the research of the clinical research of the amyloid Alzheimer's disease, but because of the intracellular deposition of tau aggregates, so these tau agents should overcome the BBB barrier, blood-brain barrier, and also cell penetration. So, and also that tau fiber concentration of tau fiber is 5 to 20 times lower than the amyloid fiber. So sensitivity is also important for a tau imaging agent. Here you can see the several different kinds of tau imaging agents, start from the FDD-MP and flow tau sphere that 1451, and THK series of compounds made from Tohoku University in Japan. And also PBB3 compound is made from NIARS in Japan. And after that, this success of development of tau imaging agent, these are first generation imaging agent, and second generation tau imaging agent has developed. So every older structure, they possess that the distorted plane structure of the benzene ring, conjugated benzene ring. So you can see the these types of biphenyl structure, and then distorted plane structure is added into the this main plane. So start from FDD-MP. They said that the FDD-MP has affinity both amyloid beta and the tau aggregates. Earlier, they insisted this compound can this compound can show the amyloid plaque and also tau aggregation. But in nowadays, we have to see the distinction of the amyloid plaque and the tau imaging, tau plaque, tau aggregates is a better choice for diagnosis of the Alzheimer's disease. So FDD-MP has gone, and after that, the specificity. So off-target binding is very important for performance of the tau imaging agent. So all these compounds has very less amyloid plaque affinity and high affinity to the tau aggregates. And also second generation also focus on the off-target effect, not only for amyloid plaque, but also MAO A or MAO B. So that amyloid FDD-MP can show the high uptake in a AD patient, and that region is hypo metabolism uptake from the FDG PET. And then, as I remember, this C11 PBB3 is the first human images of the tau tracers. So they can show the normal control and AD comparison study. So in the AD patient, they had a high accumulation of the tau C11 PBB3 in PET images. And after publishing this paper, we collaborate with the NIRS, and we have supplied by the NIRS Dr. Chang, and they gave us to the labeling kit for PBB3. And after that, we can make these kinds of normal control images. But this C11 PBB3 has a significant defect because of the they are labile and for a light. So we have to do the whole light off, even in the synthesis. So after the injection, then we can switch on the light, and then we can get the images. So for tau imaging agent, you can see the huge list of the tau imaging agent, but tau fiber has specifically has 4 different binding sites, and each compound has different affinity to each binding site, and also that tau imaging pattern is almost different between these tau imaging agent. You can see here C11PBB3 has almost no uptake, but THK compound has a high uptake, and also in vivo imaging, there are huge difference between these 2 compounds. And also AV1451 compound and also THK compound has entirely different between uptake of the uptake pattern. And sometimes frontotemporal lobe dementia, they has no there is no correlation between these 2 imaging agents. And also off-target binding of the first generation tau PET tracer has MAO A or MAO B uptake. You can see here binding target is a MAO monoamine oxidase B or monoamine oxidase A. Uptake is in the brain regions. In case of THK or AV or PB3 has these kinds of off-target binding to some region of the brain, and also other compounds has some different kinds of off-target binding in the normal brain. So to solve that problem, they wants to make a 2nd generation tau PET tracers. Here you can see the Loshi compound and then Merck compound and PI 2620 compound. So they also have off-target binding, but slightly better than the 1st generation tau tracers. So you can see here, 2nd generation tracer has some lower off-target binding or no off-target binding. So among this compound, you can see here, MK, Merck compound has no off-target binding to MAO A or MAO B. Still, there are several complexity of the tau PET. Tau PET with different clinical phenotypes and pathology, and different PET traces with different selectivity, and also different off-target bindings, and also different relationship with other pathology markers, and differences between the in vivo PET and in vitro binding. Still, but there are complexity are there, but they said that tau burden highly correlates with the cognitive function. So, so that's why every world big pharma wants to make a tau imaging agent for amyloid plaque imaging, and also that NIA and AA frameworks, they that the whole Alzheimer's disease research field has a paradigm shift from the symptom-based to the biomarker-based clinical studies or clinical data. And finally, neurodegeneration, we can see the FDG PET, that is the traditional marker of the glucose metabolic changes in the brain. So in the diagnosis of AD, that sensitivity is around 91% and specificity is 86%. So neurodegeneration, in case of neurodegeneration, we can see almost same with the MRI. And you can see the normal brain to the decreased metabolism of the neurodegeneration. And this is the final slide. So even though we have a imaging agent or imaging biomarker, if there are no therapies, then how can we do? Fortunately, aducanumab is recently approved by the US FDA, but this compound is an antibody-based compound. So antibody drug cannot, I believe that they cannot pass through the BBB. So even though they cannot pass through the BBB, they have a slightly decreased uptake of the amyloid imaging agent. So I cannot believe that compound has efficacy, but still we have hope to make a new therapeutics for AD. So sooner or later, if we get the effective drug for AD patient, then I think we can use PET amyloid plaque or tau imaging tracer for clinical use. And other group wants to make a new types of imaging agent that is related with the inflammation imaging. That next generation of the amyloid plaque or tau imaging agent. But I think amyloid or tau imaging is enough for AD clinically. For inflammation, inhibition of the inflammation or imaging inflammation is inhibition of the inflammation is better choice than the imaging because of the druggable target, the therapeutic target for AD in case of inflammation. So inflammation imaging, still several research group wants to make ROS imaging or TSPO imaging for AD patients, but there are non-specific, not that inflammation is not related with the, sometimes AD or other, sometimes AD is not, inflammation is not related to AD. We can see also inflammation imaging using the PET tracers, such as TSPO or other other inflammation imaging agents. So this is the end of my presentation. So is there any comments or question? Then you can put the chatting or the, if you raise your hand on the button of the chatting, then we can answer you.
So this is Lee of SNUH2. So I'd like to ask my colleague, Professor Yunsang Lee, until while the other colleagues on the Zoom connection is going to write down, or just to open your video and unmute you, and then you can just ask your question. The first question is regarding the off-target effect of tau imaging agent, which is MAO-B. So I have wondered since long ago that I first heard about the MAO-B, the intervention, actually MAO-B participation in the imaging of as an obstacle to avoid the popular use of the tau imaging agent. So MAO-B, does it, the enzyme looks like a beta sheet of neurofibrillary tangle, or that compound? You just told us that the bibenzene, and also the another benzene is just kind of across a bond. So distorted planar structure of tau imaging agent is going to make them taken up by the monoamine oxidase B enzyme. So is it enzyme inhibitor interaction, or is it because of the structure of that enzyme? Enzyme has a beta sheet-like structure, and that was a long-standing puzzle for me.
In my thought, I think that monoamine transferase is a enzyme.
Monoamine oxidase.
Yeah, monoamine oxidase is an enzyme. So I think that tau imaging agent can act substrate for that enzyme. So I think that enzyme can recognize that okay, that compound has a benzene ring and also monoamine is there, and then they can recognize that compound as a substrate. But some distorted structure can not recognized by the MAO-A or MAO-B.
So you mean it's kind of an enzyme substrate interaction by the tau. So that kind of enzyme substrate interaction would have been tested in vitro beforehand. So why not they have just done the animal experiment, or even they ran onto the final line to do the clinical, even clinical trial. So I wondered.
I think first of all, they in the first stage, they cannot recognize that the MAO-A or MAO-B. Then sooner or later, they can see the why they can show the normal distribution in the brain specific area. So they finally look up into that compound, and then they finally found that that is the MAO-A or MAO-B.
Mm-hmm.
Yeah.
Okay, so you have a question from Dr. Wang from Malaysia. So.
Okay.
So let me.
So
actually, let me rephrase the biology behind the question. Actually, tau has a 3-repeat or 4-repeat structure of the proline-rich areas. So it's kind of a repetition of. So every kind of neurodegenerative disease, they have interesting asymmetry or bias to have 3R or 4R. So it is related with the length of the peptide instead of the actually structure itself. And then tau imaging agent is imaging not the tau itself, but the beta sheet structure made from tau. So the Dr. Wang would have been interested in the constituent difference can be imaged by any kind of radiopharmaceutical. That was the question.
My answer is no. Because of that beta, tau or any kinds of amyloid plaque imaging agent can target the beta sheet structure. So beta ship means a highly benzene ring rich component. So that's why that compound has a very short but planar structure, plane structure of that they can intercalate that beta ship. But in case of length of that protein, maybe they cannot differentiate because of that structural, they cannot identify or differentiate the structural differences between the 4R or 3Rs.
Okay, yeah, so do we have, we have another.
Yeah, Dr. Kamalia asked to the which imaging FDG tau or amyloid correlates most with the severity of the clinical symptoms. I think Professor Seok can answer this, but I think in my thought, up to now, clinical symptom tau imaging agent is mostly correlate with the clinical symptoms. In case of amyloid, they have some early stage of amyloid plaque imaging, amyloid plaque aggregation. So even there are no any kinds of clinical symptoms in the positive amyloid imaging. But in case FDG, that very late stage of the, because of almost morphological changes happen in the brain. So late stage imaging agent for amyloid Alzheimer's disease. Am I right?
Yeah, still there, actually the FTG and tau was regarded as a marker for neurodegeneration, which means that these markers are related with the symptom, its severity itself. So I also think that, and like from the studies, I think that actually FTG and tau both are markers that are related with the severity of the clinical symptoms.
Okay. Then also one more question. That labeling yield is very commercially available amyloid PET agent. Yes, labeling yield is various each compound. So, but you don't don't have to think about these kinds of labeling yield because of the you can make a kinds of automatic radiosynthesizer from the labeling kit. So even though less than 1% of the radio labeling, and if you can make more than 10 curies of F18, then you can get more than 100 millicurie of PET traces. So that labeling, nowadays labeling yield is not so important because of that cyclotron performance is very good enough for yielding of the F18 PET traces. And Professor Tong-Soo Lee.
I think there is a question in the upper part that about could we use amyloid PET or tau earlier as an indicator to use medical therapy that inhibit amyloid deposition?
Yes or no, because of still we have some framework start from the year of 2018 that NIA and AA still coverage of insurance I don't know, in case of Korea, we can cover the amyloid PET for Alzheimer's disease, I think recently, but I think that is the somewhat different situation in each countries. So, but still we can make an indicator for medical therapeutic use for Alzheimer's disease.
Professor Lee, would you please show the Congo red staining slide, please? Okay. So let me make a small correction in your stat, because yeah, your Congo red, yeah, the first image, almost first, yeah. Your Congo red image, so everyone joining this meeting, please kind of make a little bit of fun. So if Professor Yunsang Lee doesn't mind, let me correct the tissue. So does anyone noticed, recognize that the Congo red stained tissue is what? Which tissue? That tissue is definitely not brain.
Yeah.
Yeah, kidney, yeah, correct. Okay. So I found that the Professor Yunsang Lee has adopted the first image of Google Scholar imaging, and that's from a company showing the Congo red staining of the glomerulus of the kidney, and then the other structures are all the tubules. So this you just reminded me of my the medical school days, or the internal medicine resident days. I was so much fed up with this image to find out that that's kind of Congo red staining for just the mesangium. They say that the mesangial cells have taken up. So, and then my just the continuing question is, regarding tau agent, your amyloid imaging agent was the explanation was so clear to me. So now we know that we have 4 compounds domestically. Maybe they might be available in our colleagues. I mean the colleagues' countries, meaning the all Asia. But tau imaging agents is still confusing. So the first question was the off-target the binding or labeling. And then I was curious why the monoamine oxidase B is taking up a tau. Now I understand according to your kind explanation. And the second one is, then how would they find the not other enzymes, but monoamine oxidase B is the culprit? So it's a criminal to just kind of obfuscate all those efforts. They make those efforts futile after such a kind of huge amount of money, the investment. So do you have any idea or background knowledge? So that's my question.
As I heard that, first of all, that in the clinically used available is AV1451 is only one is approved by the US FDA. And other one, I think maybe clinical phase 3 or 2. So sooner or later we can see the commercial name of the these kinds of these second generation compound. And as I mentioned that the earlier stage, they focused on the only for off-target binding to the amyloid beta plaque. that is very important. So they differentiate that the amyloid plaque and the tau. I think that maybe they focus on that point. And after that, this second generation, they check up the in vitro with the MAO A and MAO B also.
Okay, so then the how they at the beginning, the monoamine oxidase B is the kind of a culprit and suspect to be involved in the off-target. So there was a really, and would you please show the table, the summary of the off-target effect? So actually, we are the customers of the radiopharmaceuticals, which were developed by the experts like you. But when we are using not that one, it's just kind of I have seen the thalamus and some kind of this one. Yeah, off-target effect was the left lower table, basal ganglia and thalamus, MAO-B, and THK family tracers and 3 positive. PBB3 is also 3 positive. AV1451 is also 2 positive. So they have just designated basal ganglia and thalamus. So meaning basal ganglia and thalamus are the remote area which is taking which is harboring, which embraces the neuraceq plaque or tangles. So that's kind of in case of the FDG PET, sensory motor cortex and deep gray basal ganglia thalamus are free from any decrease in FDG uptake. So those areas are might be full of that enzyme. We don't know. So let me just show you the mine. Just for, would you please the unshare? Let me just show you the mine, just a kind of a continuing of the transcriptomics, which I have shown you in my last lecture, last semester, and which is going to continue again. You know, the scripts are small, but here, first 3 animals are from normal controls, and the next 5 animals are from the Alzheimer disease model. And then next 4 is kind of a treatment cases. And the first row is monoamine oxidase B. And second row is monoamine oxidase A. Third row is tau meaning MAPT. And fourth row is amyloid precursor peptide, APP protein. So at first glance, there is no difference between the transgenic and also normal controls. And then what about the monoamine oxidase? Here is thalamus and then hypothalamus here. And hippocampus is over here in mouse, and then isocortex or the neocortex is here. Amyloid, amygdala is here, and striatum is there. And we have piriform cortex, which is specific to mouse. So as you just have seen, the monoamine oxidase B transcriptome, mRNA, is highly expressed in thalamus. So thalamus uptake is there, and monoamine oxidase B is a kind of a problem. Then now I think I can understand better, but still I don't understand how the radiopharmaceutical scientists, they have found off-target is is by monoamine oxidase B. So that is still a kind of a puzzle to me. So because of that, I respect the developers and then the chemists who made the discovery. Even though they have done from the beginning to find to just kind of narrow down, pinpoint the radiopharmaceutical of a bright future, they have not checked. They have any kind of off-target substrate enzyme interaction. So they have lost a lot of money, and they would have been fired from the Merck and Pfizer or AstraZeneca because of their failure. So is there any question, or then there was just kind of a little play, and that's kind of a exemplary presentation. You use only the typing for questioning, for asking questions. So why don't you just use the scheme like me? You can show your reference to the lecturers by just sharing your computer screen, and then just ask some questions. And sometimes, just like me, you can just ask the lecturer to show his or her own slide, and then just to say, it does not look like brain, then what's the organ? So that kind of interactive, asking questions and then answers, that might be the next step. And I hope Professor Yunsang Lee would not be bothered by my just kind of joking. Okay. Professor Seok, please. You can continue.
Okay. Okay, thank you very much, everyone. And especially thank you for Dong-Soo Lee for correction of my slide. Thank you.
Okay, I think the prepared lecture seems to have ended a little early. However, this lecture is a pre-cur. This lecture is a pre-cur to the lectures that will be held next semester, as you can see in the slide. So I think the next, so please attend the lectures that will follow. So we will start the second fall semester from September the 1st. So as you can see, mostly the lectures will be dedicated for the neurodegenerative diseases or brain imaging, and also the therapy of the brain. And also, like, as you can see, the green part, actually, I would like to introduce is scheduled by the request from your surveillance. So we are doing surveys for every lectures, and there was a request for such subjects. So we have scheduled lectures regarding PSMA, OPP, and about the correlative imaging of lymphoma and hepatoma. So I, again, would like to ask all you guys to please attend the lecture that will follow. So yeah, and actually the Asian countries, including Korea, are still in the COVID-19 situation and struggling. However, I believe that this difficulty can also be overcome with the effort of you guys. So I look forward to the day when we can meet and talk in person, and let's finish the session. See you again at September, and I wish everyone good health. Thank you very much. Okay, thank you.